forward. So without further ado, I would like to introduce Nathan Valentine. Nathan is the Chief Quality Officer for the Oklahoma Healthcare Authority. And prior to this role, he served as the Senior Medical Director at OHCA. He graduated from medical school at the University of Oklahoma and completed a family medicine residency in Wichita, Kansas. He's a board certified in family medicine, and he has a focus on hospice and palliative care. After 2 years of leadership training while working full-time, he completed his CPE, or Certified Physician Executive, through the American Association of Physician Leaders. We are just really grateful for Dr. Valentine's effort and work at the Oklahoma Healthcare Authority. And so without further ado, I'd like to hand over the screen to Dr. Valentine.
Thanks, Hallie. Hello, everyone. I'm going to go ahead and make an attempt here to share my screen, get the slides up. I don't think that one worked. Let me try another one. There. All right. So can you all see the Sooner Care Expansion title slide?
Yes, we can.
Wonderful. Okay, I'll put it in presentation mode here. Well, apologize. I think I'm having some issues with my display on this side. I'll get it sorted here. So as I resuscitate things, I'm having all kinds of interesting experiences with technology today, as Hallie can attest to. But I think we're going to get over the hump here. Okay, so as Hallie said, I'm the Chief Quality Officer at the Oklahoma Healthcare Authority. Before I came to the agency, I was also in the FQHC sector, both statewide from a quality improvement perspective and as a practicing family physician. And I appreciate the opportunity to speak with you all and learn about what you all are doing, and also kind of share some of what OHCA is doing right now. I'm going to go over just real quick the available data that we have on the expansion members. A lot of this tends to be snapshots of periods of time because we are dealing with the limitations inherent in claims data. And then we'll go to the SoDH activities, the social determinants of health activities that we are currently working on. And then I'll end it with a little look toward the future as we look to develop more things for proactive QI for Medicaid members. So real quick, I thought it might be helpful. Let's see. I thought it might be helpful to just kind of review the eligibility and the coverage. I'm sure this is out there, but as far as thinking about who are the folks who are signing up now, the household income has to be at the 138% level of the federal property level. They are adults, of course, 19 to 64, because the children are already covered. They're not pregnant because pregnant folks are already covered. And U.S. citizen or documented alien cooperation with child support is a prerequisite to continuing to getting onto Medicaid and continuing to receive the benefit. Oklahoma resident and not Medicare eligible. The coverage is essentially the same, or in some circumstances better than what the individuals used to have. I say it that way because some of these folks are new to coverage and some of them are Insure Oklahoma, basically being brought over into this same coverage eligibility group. There are no premiums. There is a copay that is possible for the members up to 5% of the monthly income, unless exempt. The copay for most things is $4, and that has not been a barrier to date, but it's something that I watch from my perspective as the Chief Quality Officer, trying to figure out what barriers our members may have. So what do we know so far? The updated number yesterday was 180,949 that have signed up since expansion, and we started taking those in the beginning of June, you might remember. What do they look like? This is just kind of a smattering of what we know about them so far. We have a process where they, of course, apply, and then there's an optional survey to tell us more about them and more about their needs, so that we can connect those with high intensity needs to services. So just in general terms, if there's a 60-40 split, 60% female, 60% of the folks have been in urban areas. The race and ethnicity percentages are actually comparable to pre-expansion, and there's about 19% tribal folks. The clinical needs that we're identifying, this is approximate based on July's responses, which was a little over 1,500, I believe. The folks who are signing up, I will say they have been giving us, they're engaged. They've been giving us, volunteering their time to keep answering those questions, which not everybody does. And in the past, there was a much lower rate of response. But what we're finding out so far is this is kind of representative of what we're seeing. Close to half use tobacco products. 9% have had an acute hospital stay in the past 3 months. 7% have used the emergency department more than 3 times in the past 3 months. And there's some other things you can see there on the slide. 47% have a mental illness, 17% have diabetes. The general trend is what we might expect. More than one chronic condition, delayed care because of a lack of coverage. The stats that we're seeing so far are consistent with those characteristics that we would expect from an expansion population. And looking at just kind of how the utilization spreads over the age groups. Again, this particular view is the first few weeks of September. And what you see is really that in the over 45, those who are over 45, they account for about 25% of the enrollment and about half of the expenditures. So that's another interesting point. And what I wanted to do here was transition over to a discussion of social determinants of health. We have targeted programs at OHCA to look at what are the health-related social needs for folks who are utilizing a lot of services. And we are going through a process of evolving that. But what it means is that we have pockets of data about certain people that we provide coverage for. And so that's why the view of the data can be a little bit limited depending upon on what's available at the time that I engage with the community. What I wanted to do here was switch over to social determinants and talk about kind of just a couple of slides about why we're here. This is the kind of stuff that, we've all heard about social determinants. We've all heard about the need, obviously, and that's why we're here today. I do think it's interesting to point out just real quick an example of a disparity, health equity issue that is present in nearly every state. And you can see Oklahoma on the far right of the screen here with a relatively larger gap than most states between the mortality amenable to healthcare in those who identify as Black or African American and those who identify as Caucasian. So, of course, what we think is that underlying that one way to address that is to start addressing social determinants of health. I say start, we've all been to some extent doing that, but finding out what are the particular aspects that would help address this equity issue as well. That's in the forefront of our minds as well. And then this is the view of again, I'm sure something like this has been seen in many places. The bottom line is that 80% of healthcare doesn't amount to that. 80% of the outcomes for the population don't come from that exam room or that delivered healthcare, and that's what we have all been struggling with, and will continue to try to address. How can we meet these, both identify and meet these needs in a way that not only meets the acute need, but also with an eye to putting systems in place to prevent recurrence of the need. So what are we doing as far as social determinants of health activities right now at OHCA? We have some screening, and most of them are linked to intervention in one form or another. We have dedicated folks internally and with our contractors who are doing this on a daily basis. So we have, for example, high-risk newborns, the 10 highest risk counties in the state. All the births there are contacted by staff in the PCM unit, and they go through the screening tool. Then there's other segments of our population that we are attempting to identify and identify the needs and connect with social service organizations that can meet those needs. And these are examples of some of the other populations. So one would be chronic disease affected folks who are not in senior care choice, which is our PCMH delivery model. An example of the chronic conditions would be hepatitis C, sickle cell, hemophilia. That's an internal unit that works on that as well. I didn't want to leave out PACE. That is something that has a lot of regulations tied to it, and doesn't often come into the senior care discussion, but it's part of the OHCA fold. So they certainly, in the program for all-inclusive care for the elderly, they certainly get to know every member extremely well, kind of the far end of the spectrum as far as understanding all the potential determinants in a person's life that could affect their health outcome. And then chronic disease in members who are part of our senior care choice PCMH program. Those members will also get screened. And as it says on the slide, we use the AHC tool primarily, the Accountable Health Communities tool, and then we connect them. Now, the advantage, there's a number of advantages to participating in PCMH, but one of them is that the health access networks, health management program become available to those members to help meet needs, both from a complex coordination perspective and from a health-related social needs perspective. And that ranges from connecting the services to actual health coaches and academic detailing for the practices. Other things that fall into that bucket of social determinants activities, Sooner Ride, which I'm sure you're all familiar with, non-emergent transportation, obviously to medical appointments, also to the pharmacy after a medical appointment. And then it's worth noting the meals and lodging. Housing and food insecurity are something that we are always cognizant of, and we do have some ability to help with that. If a member has to go far from the home for their appointment or appointments, it used to be that you had to go 100 miles before this kind of help was possible. Now we can offer that help if it's just 50 miles from your home that you're going to get the care. So that's one element as well. And I want to just point out that the PCMH model, because it is structured to pay in a more effective way for practices that coordinate the care of their members, it is the hope there is that we're creating infrastructure, helping create infrastructure within practices to screen and meet those needs. So what's planned in the future? One of the things that we are working on, the timeline is a little bit soft. We originally hoped for an early next calendar year, like a January rollout. That may be stretched a little bit depending upon a couple of things falling into place, but we are going to start reinforcing, or if there's areas of the state where the courses aren't available yet, actually giving those courses through collaboration with community partners. We have staff at the agency that will also be able to give the course if necessary. But our focus, of course, is statewide, starting in the highest need areas to provide courses that help with building life skills. And basically what that means is it's using an evidence-based solution for improving resources in adults. And that's allowing for improvements in both soft and ROI types of indicators. So perceived stress, mental health and well-being, social support, hope, goal-directed behavior and planning. And you can see that the ROI factors, the monthly income, total debts, even assets, and their percentage that end up changing the amount that they're relying on safety net services. These courses, while small, each individual course is small, they have significant measurable benefits to the investigators who go through them. And so the Getting Ahead course is the initial one that will be rolled out, and we'll have others down the line, hence the term menu of life skills courses, because the idea is we have a very large population, and the Getting Ahead course helps adults, but we want to help our teenagers, and we want to help adults perhaps with special needs. So we have a lot of work to do on that front. It's just the first step, and it really has the potential to meet the need for how do we make sure that the health-related social need that we identified today and that we meet today because of the great work of so many community members, how do we make sure that that doesn't come back 6 months, a year down the road? And there's some potential there, and that's why we're getting these going. Other things that we'll be doing: systematic measurement and continuous quality improvement for social determinants of health indicators. Easier said than done, of course, because the data systems for social determinants of health indicators is pretty far behind the rest of the quality indicators out there. However, we will develop a way to measure and regularly report out on these and try to help providers understand where their members lie, so that we all can be managing our populations. And developing direct certification with the Department of Education, so that by virtue of being on Medicaid, children can receive reduced or free lunch. This has shown wonderful benefits in other states, and this looks to be a very promising way to help our population out. And it's always nice, you know, I'm a family doc. It's always nice when we can find a solution that removes paperwork. So that this will certainly be doing that. And I think there's the references, and if there are general questions, I can, of course, take some when we get to the Q&A, but there's also these ways of contacting the agency. And I will stop sharing now and see, Hallie, if we'd like to address any questions, or if we go on to another segment first.
Great. Yeah, we're actually, we are ahead of schedule. So we can open it up to questions. For Q&A, please feel free to open, to write your questions in the Q&A section and or the chat box, all of which we can communicate with Dr. Valentine and kind of hear his thoughts on that. I guess one question, I think it's an obvious question to start us out, is how do you feel Medicaid expansion has been rolling out? As far as, do you feel like it's been a smooth transition? What are your thoughts on just the actual enrollment process?
We've we've been real pleased. I think our enrollment eligibility department has done a fantastic job of planning for and implementing that. We do monitor it on a regular basis. One of the things they look for is there's an actual survey about the enrollment process and making sure that we're hearing the members on how just that process goes. So far, it has looked to be quite smooth, but we are remaining vigilant and watching everything we can on it. To be honest, it's in the forefront of our minds.
Absolutely. And then there's a question in the chat that is from Alana, and I think they're asking about the acronym AHC. So what is the AHC tool for SDOHs?
Sure. So actually, I'm gonna see if I can pull up a file and show kind of what we're using. So the Accountable Health Communities is a grant-funded process that's happening in multiple places in the nation where an organization can basically either screen and meet or align other organizations to screen and meet health-related social needs. And so there is a survey that CMS put together, and while each grantee is allowed to tweak it just a little bit, there really is some stability across each organization that's using it. And basically it screens in general areas of housing security, food security, whether or not you're affected by violence in the home. And I think I do have a file here I can get ready and show a little better. So I'll just kind of scroll through it so you guys can see the questions. But basically it screens for 5 general areas of health-related social needs.
Are you able to share your screen?
Oh, no, I'm not yet.
Okay. Sarah, would you mind handing over control on that one? Thank you.
Thank you. And there we are. So you can see that, and I apologize, it's really just crude screenshots from our internal system, but gives you an idea of the questions. So they answer questions about ER use, of course. That is actually part of the grant requirements. And then they ask about living situation, whether you're affected by these kinds of problems in the home, mold, pests, etc. And then they go on to ask about food, transportation, utilities, safety, and then just demographics. So this is the tool that both that care coordinators, care managers, social service coordinators are utilizing to screen for health-related social needs.
Well, and that's a really great segue into another question that we had from a participant from Susan, and they are asking about Prepare, which the FQHCs are encouraged to use. And so the question that they posed is, as an FQHC, we have a case management program that addresses the social determinants of health. How can we work with OHCA since we have a large Medicaid population as well? What are your thoughts on that?
That's a great question. I would love to find a way to work with the FQHC groups a lot more than we do now. You know, the agency is small for a reason. We have been, we always try to be very good stewards of Oklahoma's dollars, and that leads to us being quite small. But we are also building up our QI quality improvement team now, and that's going to allow us to do a little more of that work with the FQHCs and others. The Prepare tool is a wonderful tool. I think CMS just had they just chose to use their particular tool. But I think the Prepare is just as valid, and I've used it in the past myself.
Great. There is a question around geographical regions in the state. Are there any geographical regions in the state that are lagging with regard to sign up for Medicaid? And also, Sarah, if you can share your screen again, that'd be great.
That's a really good question. I don't have a specific answer for it though. So let me check back with the agency folks and see what I can find out specifically on that one.
Great. And then here's a question from Dylan. With over 180,000 new enrollees, is there any indication that the healthcare system is having difficulty keeping up with enrollment? For example, are new Sooner Care members able to get access to healthcare that they need? Has claim data increased in the short time since enrollment began?
We are seeing some increases on the claims data and kind of prior authorizations and that sort of thing. It's straining our smaller departments like our dental department, they're doing a great job in general keeping up, but it's a lot more volume than they're used to, which of course is a separate topic, I suppose. But at the same time that we did expansion, we also added a dental benefit. So that plays into it. So the second part of that question was claims. The first part, remind me, what was the first part?
Are new Sooner Care members able to get access to healthcare that they need?
Yes, that is one of the questions that we ask them in our routine recurring surveys to see how their experience of care is in the early days of enrollment. And so far, we have actually been pleasantly surprised. We were a little worried about certain pockets, but we've been pleasantly surprised with everyone being able to get an appointment when they needed it. So we will continue to watch that and continue to try to work with the provider community on improving access where it's needed.
Great. Martina is curious about outcome data that you mentioned from the Getting Ahead courses. Is that national data, state, or local?
That is national. The ones that I mentioned were national studies. The size ranged from a few hundred to a couple thousand individuals going through the courses and having pre and post questionnaires that then get aggregated. So like I said, Hallie, I'll send you my slides, and there's references listed there. You'll be able to see the specific publications on that. It's been quite promising, but there is variation across the nation. And we've had these courses in the state for a while. COVID really knocked the wind out of the effort, I think. The organizations that could go to virtual did. For example, facilitators continue to get certified virtually. Some of the actual courses continue to operate virtually. But honestly, it looks like, we've done a survey and it looks like about half of the courses that were there before COVID are no longer there. So it's a concern for us, because if the folks in those courses are not on Medicaid, they certainly are likely to be eligible or be some of the population that kind of hops on and off Medicaid throughout the year. So that's something that we continue to keep an eye on.
Well, and a follow-up to the enrollment and access to primary care questions, Gregory Grant was wondering about patients being able to access primary care in a timely manner, and if there's a difference between rural and urban areas in respect to that.
Yeah, and I have to look back at that data to be able to speak to that accurately. We have not seen any problems so far, but we do have 40% in the rural area signing up. So I would think we would have started to see a hint of that, but I will reference that data and I'll send it into you, Hallie, so that you can forward it on to the participants.
Great, thank you. And then the last question that I have is about the meals and lodging benefit. Do families contact their care manager to access those things?
Exactly, or just call the agency and they'll get you to the right person. But yes, if you're already connected with a care manager, definitely they can help you set that up.
Wonderful. Well, thank you so much, Dr. Valentine, for your time. We really appreciate your expertise and all that you do for the state. It's wonderful to see how you're leading with data and using that to inform the work that you all are doing. So thank you so very much for that.
Thank you. I appreciate the opportunity to be here.
Great.